Good morning, Professor. My name is Kathleen Kihala, and I'm going to be talking to you a little bit about pulmonary function testing. So when is PFTs recommended? The most common one that we see at bedside would be with patients would be the spirometry test or the peak flows. Those are basically indicated to patients who are showing signs of breathing difficulties and for whom the physician and respiratory therapists are considering the need for mechanical ventilation. For example, if a patient has like a progressive neuromuscular disease or worsening cardiopulmonary conditions, it would show a smaller vital capacity and a maximum inspiratory pressure, or MIP, or MEP, which is a maximum expiratory pressure, as he or she weakens. With the mechanical ventilated patients, if they improve, the bedside spirometry is used to evaluate the patient's spontaneous breathing for weaning. There's three major rules that we should always have in mind to rule out airway obstruction in patients with respiratory symptoms, to assess the presence and absence of airflow obstructions in patients at risk for COPD, and lastly, to assess the severity of airflow obstructions in patients with dyspnea or other respiratory symptoms. So what we'll be doing during the pulmonary function testing for patients, we will basically monitor all the patient's vitals, make sure the patient's heart rate, pulse doesn't get affected during these maneuvers, because sometimes it can also accelerate it, and it's not good if it accelerates it, so we just have to monitor those. There's going to be a lot of steps towards a spirometry test. So the first one, if a patient has medications to take, we would be basically doing the spirometry test after each medication. So there's a whole lot of list of things that we'll have to take in consideration, because there's different medications that have long lasting or long acting, such as a beta-2 agonist. After 6 hours, it'll basically wear out. So we have to take the test in a timely manner. So another one will be a long-acting beta-2 agonist, and that lasts after 12 hours. For these tests, we just have to make sure, again, just monitor the patient's heart rate, pulse, hopefully won't have a fever or any other type of symptom. Continuing on with the preparation and procedure on how we're going to explain to the patient. First, we're just going to explain the purpose of the test and demonstrate the procedure, record all the patient's age, the height, the gender, note what kind of bronchodilator or medication they took last. We'll ask the patient to sit comfortably, more likely sitting up. Hopefully they'll be wearing loosened clothing. Hopefully they've went to the bathroom and have their bladder empty. They'll breathe in until the lungs are full, and then they'll hold the breath and seal their lips tight around the clean mouthpiece. And then when they're ready, they're going to blast air out forcefully and fast as possible. If it's a bedside spirometry, they would basically breathe in deeply and then forcefully blow out air. If it's a forced vital capacity type test, they would have to have a lot more encouragement, because they're going to have to breathe in as deeply as much as they can, and they have to blow out as much as they can. And they basically, sometimes they would turn color, their lips will turn a different color. So at that point, it's going to be a little bit of a lightheaded kind of situation, but hopefully not to that extreme. After they continue blowing until their lungs feel completely empty, we will watch the patient during the blow to assure that their lips are sealed around the mouthpiece. We would also check to determine if an adequate trace has been achieved. We will basically repeat this procedure at least twice or more until we have three really good readings, and then we'll just pick one and we will record that in the patient's chart. So what does BTPS mean? And why is it important to performing a good PFT? Well, BTPS means body temperature and pressure saturated. We normally convert ATPS to BTPS, and this is the equation that we use. So aside from the challenging of changing temperature and humidity inside the patient's lungs, the ambient pressure is also important to consider, such as like flight altitudes in the air, where the medical transporters, they reach up to like 14,000 feet in the air. So the helicopter rescue missions regularly go to these altitudes, and they require the body to adapt. So the alterations associated with the changing in the ambient pressure can have significant impacts on the ventilation volumes that is delivered by the ventilator. When patients are on mechanical ventilation, it's fixed wing aircraft without a pressurized cabin is subject to the same dynamics. In case of a pressurized cabin, it is relevant to correct the inspiratory volumes, as the cabin is usually maintained at a pressure of approximately 800 MBR, or like 600 millimeters per mercury, comparable to an altitude of like 8,000 feet in the air. So that is the importance of the BTPS. So what are the difference in these testings that we can do with the patients? The first one is peak flow meter, or the body box, also known as the plasmamography, spirometers, helium analyzers, nitrogen analyzers, carbon dioxide, monoxide, and methane analyzers, MIPE devices. So on this page and on the next page, there are going to be a few images, and these images are basically instruments that we'll be talking about. So the first one, the peak flow meter, measures and monitors the PEFR for patients with asthma. The patient will exhale forcefully through a device, which is like this one, and it incorporates a resistor and a movable indicator for accuracy and effectiveness by the patient efforts. The moisture and debris can affect the accuracy. For the next image, the body box is based on Boyle's law, which states that the pressure and volume vary inversely if temperature is constant. It measures thoracic gas volume, which is the same as FRC, the functional residual capacity. It also measures airway resistance, which is the difference in pressure between the mouth and the alveoli, related to the gas flow at the mouth. The next image, which is the spirometer, it measures volumes and flow rates. It's used for spirometers in pulmonary function labs, or it's also for patients that after post-op, or patients that have atelectasis. It's normally portable, and it can be used also at bedside. Continuing on with the first image is the helium analyzer. It has a thermal conductivity. It also measures in percentage. The analyzers are calibrated using multiple point precise gas concentration to establish linearly. Calibration is performed under the same conditions and physiological range that measures that will be taken during the test. The next image is the nitrogen analyzer, and those are used by the Geissler tube ionizer. It is also measured in percentage, the same as helium. We have to calibrate it to 0 with 100% oxygen and 0% nitrogen, and to a known concentration of nitrogen. The calibration to the room air at 0% and a known amount of nitrogen, about 10%, and then we would basically re-zero it and redo it all over again if it doesn't work. For the next image, the carbon dioxide and carbon monoxide and methane analyzers, the carbon dioxide is measured via infrared absorption analyzer. It's a quick response for diffusion or DCO measurements. It's calibrated to room air at 0% and to a known concentration of 0.3% of carbon monoxide, and then re-zero. For methane, It can also be used in infrared absorption. It's not affected by changes in partial pressures like altitudes. Long sample lines and moisture can adversely affect the calibration and delay the response time. And the last image is the MIP or MEP devices, and those are measurements of maximum pressures. So the MIP is used to monitor and assess the readiness to wean in ventilator patients. It assesses the degree of respiratory muscle impairment in patients such as Guillain-Barré or myasthenia gravis. Inspiratory pressures are described with negative numbers. A normal MIP is around 80 centimeters of water. Anything below 20 centimeters of water is indicated for an inspiratory muscle weakness. And the MEP, which is the maximum expiratory pressure, it's helpful in evaluating a patient's ability to maintain an airway and clear secretions, ability to cough effectively, essentially. Expiratory pressures are described with positive numbers, and a normal MEP is 160 centimeters of water. Anything below 40 centimeters of water is indicated for a poor ability to clear airway secretions. So how do we explain the procedure of an FVC maneuver? So the FVC basically measures how much air the patient can breathe in and out of their lungs. It's literally testing the vital capacity, which measures the maximum amount of air you can exhale following a deep breath. This barometer will measure how much they exhale. Normally we would do this about 3 times or as how many times we can to get the perfect one. Let's start the whole procedure and explaining it to the patient. What the patient will do is they will breathe in normally in the beginning, and then they will take one huge breath in and exhale as much as possible until their lungs feel completely empty and cannot blow out anymore. So once they're ready to begin, they will make sure that the patient is focused without any distractions. Their position is important too. They basically have to be sitting up straight with their back against the chair. Shoulders should be drawn and the eyes should be open. Both feet on the floor with the legs together. The patient would also have to put on a nose clip. They apply that, and hopefully that they cannot breathe with the nose clip on. So the patient has to begin breathing normally. And then when they're ready, after 3 normal breaths, they're going to take one forcefully breathing in deeply as much as they can all the way. And then they have to blow forcefully out until the patient cannot blow out anymore. Once this is done, we will review the results. We'll make sure that this is all accurate, have the patient relax, record the best result, and then record the best result on their chart. In summary, this picture right here is a simplified algorithm that may be used to access lung function in clinical practice. It presents classical patterns of various pulmonary disorders. As in such diagram, patients may or may not present with classical patterns depending on their illnesses, severity, and lung function prior to disease onset. For example, if they start with a vital capacity close to an upper or lower limits of normal, or LLN in this picture, it basically, the decisions about how far to follow this diagram are clinical and will vary depending on the questions being asked and the clinical information available at the time of testing. The forced expiratory volume in 1 second, or FEV1 are divided by vital capacity ratio, and vital capacity should be considered first. TLC, which is the total lung capacity, is necessary to confirm or exclude the presence of a restrictive defect when vital capacity is below the lower limits of normal. The algorithm also includes diffusing capacity of carbon monoxide, which is DLCO measurements, with the predicted value adjusted for hemoglobin. In the mixed defect group, the DLCO patterns are the same as those for restrictions and obstructions. This flowchart is not suitable for assessing the severity of the upper airway obstruction. However, we should just keep all of these in mind and be mindful of how we should treat the patient.